Yeah. So, adverse effects of PPI, what do we know? Actually, plenty. And I recommend this paper to everyone. You look at that circle and just about every adverse effects and every complications outlined there. It's a paper of Dr. Vasey and Colin Howden. And at the end of that, they outlined the issues. So almost all the data are retrospective, large databases, the odds ratio low, around the 2 or below, and lots of confounding factors which cannot be controlled. Most patients with PPI tend to be older, and they also have comorbidity. And at the end of that, in that paper, they presented Hill viewpoints or criteria. And these are robust criteria trying to document the strength of causality when you have an association between two events. Hill, by the way, was not a physician. He was a statistician. There are 9 of them, and you can go through, and they cover everything from strength, consistency, temporality, and so on and so forth. And if you go and read that paper, they covered every adverse event. I put here the main ones. You look at enteric infection, fracture, renal dysfunction, dementia, pneumonia. By the way, most people are most afraid of dementia for very obvious reasons. And the only thing that had a moderate strength was enteric infection. All the rest had too many holes. Okay. So this DDW, there are a few oral presentation on complications of PPI. This is an analysis of 11 studies, all observational, looking at the association between PPI and dementia. More than 300,000 people covered. Those marked heterogeneity. And this is, in a nutshell, what it is. There are 3 groups, and basically they're divided based on the type of analysis. So it's either hazard ratio, odds ratio, or a difference in the means. And when you look at all of them, essentially the results hug the central line, and the congregate definitely cross the central line. So there's really no evidence of solid causality here. That's a paper about Dr. Moayetti group, looking at the adverse effect of PPI, randomized trial, pantoprazole versus placebo, 53,000 patient years. This actually was not the original part of the study. The original study was a randomized trial looking at rivaroxaban or aspirin or a combination in patients with stable cardiovascular disease. Primary outcome of the original study was looking at mortality for this combination. Then they piggybacked an arm of PPI versus placebo and gathered information about 17,000 people. The follow-up is median, 3 years, but numbers is very large, and this is prospective. And when you look at the complications, this is pantoprazole versus placebo. You look at MI, stroke, all cancer, GI cancers, all causes mortality, no difference between the 2 groups. So pantoprazole did not really make a difference. You look at pantoprazole and placebo, now pneumonia, fracture, CKD, and so on and so forth, no difference. At the bottom, all enteric infection, there was a difference, as well as perhaps a little bit on the Clostridium difficile. But when you look at the number needed to harm, it is huge. So you have to treat 900 patients to see an enteric infection with PPI. So even though it made a statistical difference, clinically, I would say not terribly relevant. So in conclusion, there was no statistically significant association between PPI and any long-term harm evaluated, with the possible exception of enteric infection. All right. PPI and clopidogrel. So they did a systematic review, meta-analysis. So what's the story of clopidogrel and PPI? Clopidogrel given to patients with cardiovascular disease to prevent thrombotic events. Get metabolized in the liver to its active metabolite, which then can cause GI bleeding, as we all know when we are asked to come and scope patients who are on clopidogrel and aspirin. PPI, however, by competitive inhibition, also have to be acted by the cytochrome P450. So if you give the two, there is less active metabolite. And if there's less active metabolite, could these patients have less active clopidogrel, and maybe they'll have more cardiovascular events. So that's the reason why the FDA put these two, and if you look at the FDA label of these two, it will say that you cannot really give them or should not give them together clopidogrel. So this analysis, 7 RCTs, 3 evaluated AEs. They look at clopidogrel and aspirin. And the bottom line is as follows. There's definite reduction in upper GI bleeding when you give the PPI together with the clopidogrel. There is no substantive difference in cardiovascular events. So Colin Howden, who gave kind of a summary over this at DDW, revised that table, and now the dementia is very, very, very weak strength of causality between the two. So what have we learned? Basically, what we already know, if we read that literature, we're just more reassured. And the bottom line is simple. If you give PPI in the right dose, you give it to the right patient, you follow up your patients, and just not let them go with the PPI forever, PPIs are extremely effective and very safe medications. I think it all prepares that for a better discussion with our patient when they raise the risk and are concerned about taking PPI, and the next time we get a patient who is discontinued PPI because their creatinine is 1.1 when they need the PPI. All right. Next topic, we move into some complication of procedures. And this is a study on Barrett's esophagus in as a long-term complication of sleeve gastrectomy. So what do we know? Sleeve gastrectomy has taken over Roux-en-Y, and it's now the most frequently performed bariatric surgery. There's some conflicting data as to whether or not it's refluxogenic, but if you read the aggregate and you read the larger paper on it, it's associated with more reflux. Most centers will not do that if the patient has severe erosive esophagitis or Barrett's esophagus, but there's no standardized approach as to how to evaluate them before and what to do with them after you have done the surgery. So this is the meta-analysis. On the left, you see the search term, the inclusion criteria, all have to have an endoscopy before and after. And on the bottom, on the left, out of 7061 paper, they selected 10 that fit the criteria. And circled in red are those with the longest follow-up, 5 years or more. Excellent follow-up because essentially all had post-endoscopy. Okay, so they did not drop patients. And that, again, essentially the analysis. And when you look, there's more in the short-term studies, all to the right of the midline, the long-term studies to the right of the midline, and in the aggregate, again, right of the midline. And 50% develop new Barrett within the term and the duration of the study. So it is remarkably high number in that literature search. So what have we learned? That it is refluxogenic. Surgery can induce reflux. Do we know what the predictors are? We are not sure. Who will develop Barrett's? We don't know. Who should we avoid sleeve gastrectomy beside the obvious severe erosive esophagitis and Barrett? Should we screen all patients after sleeve gastrectomy? How should we follow up? There are no standardized criteria at the moment by any of the societies, and it's pretty much operator dependent as to what to do. Along the same line, randomized controlled trial comparing POEM with laparoscopic helomyotomy in the treatment of achalasia. So what do we know here? POEM, as you know, is gaining popularity, and it's now is the preferred intervention if you have a type 3 achalasia, particularly if the spastic segment is very long, because when you do a laparoscopic halar, it's difficult for the surgeon to go above the pulmonary vein. So if you have a very long segment, POEM is particularly useful for that. Short-term result, show comparable efficacy between both Heller and pneumatic dilation for the type 1 and the type 2 achalasia. Long-term data are lacking, and when I say long-term, I mean 5 years and longer. So plenty of information about 1 year, 2 years, 3 years. The only RCT was POEM versus pneumatic dilation. It shows a better clinical improvement with POEM, comparable physiological variables, but significantly more erosive esophagitis. Not just symptom, these are EGD-proven erosive esophagitis post-POEM. And remember that POEM, unlike Heller myotomy, when you can do an anterior fundoplication door, provides no protection from reflux. So that study that came from Brazil, 50 patients in each arm, 1 POEM, 1 Heller, 20% have Chagas. So that population is different than what we see and what just about every other center except Southern America see. We don't see really Chagas to speak of. Prospective, they evaluate them carefully with endoscopy, manometries, time, barium swallow, and so on and so forth. Same post-operatively, looking at adverse events. Primary endpoint, efficacy and esophagitis. Short follow-up, 1 year. And in a nutshell, the results, adverse event, hospitalization, about the same. Shortened anesthesia time and shortened procedure time with POEM. Clinical response, the same. Barium column, LES pressure, all comparable. Esophagitis, much more in the POEM group. You notice on the left, on the sample, there's a huge dropout of patients. So this is one major criticism. However, it made it to an oral presentation because it is the first randomized control trial of Heller myotomy versus POEM. So what do we know then, and what have we learned? In a randomized controlled trial, POEM is comparable to Heller. Erosive esophagitis significantly more common. Same question as for sleeve gastrectomy. How do we follow this patient? What are the predictors? Should there be PPI for all? Some of the practitioners who I know that do POEM put every patient on PPI. So the point behind these two papers is that we lack plenty of data on long-term effect of this procedure, and it will really be good for societies to tackle the issue and educate us as to what to do and how to follow these patients. Moving on to GM for gastroparesis. Now, if you do POEM for the esophagus, why not do it for the stomach? So you do the same technique, tunnel about 2 inches or 1.5 inches before the pylorus and the pylorus, and now you had basically a myotomy of the pylorus. So gastroparesis, as you know, chronic debilitating disease. Medical therapy, there's a limited menu of prokinetic agents and antiemetic. Surgical therapy essentially relegated to putting a J-tube and perhaps gastric electric stimulation for those who do it and for the patient who fulfills certain criteria. The origin of the symptom is multifactorial. There's accommodation issue, pacemaker issue, muscle abnormalities, small bowel that is involved. Very difficult to know where symptoms are originating in your patient with gastroparesis. And the relationship between delayed gastric emptying and symptoms is not clear-cut. And some patients have increased pyloric tone. So enters G-POEM, essentially a medical drainage procedure. There's a whole session dedicated to G-POEM, and I'm not going to review in detail every one, just basically give you the essence. This is a multi-center study, 80 patient, 36 post-surgical. And I mentioned the post-surgical because there's a difference between a patient that was perfectly healthy, you do a vagotomy, and then they have a problem, versus patient that has medical gastroparesis with multiple problems, where the pylorus may be just one of them. So it's always good to figure out what is the response of the subgroups in any one of those presentations. So the follow-up 1 year, improved symptoms and quality of life by questionnaire and gastric emptying. There was no data on hospital admission, ER admission on atresia status, which is one should be one of the main things when you follow a patient with gastroparesis, because it's the in and out of hospital admission, which is so bothersome, so costly in this population. Another study. Now, there's a double pyloromyotomy. When you do the G-poem, you do it on the greater curvature. These people decided to do greater curvature and lesser curvature. So basically, the 12 and the 6 o'clock position, 90 patient, median follow-up, short, double myotomy, patient did better. All are open label, mind you. And this is a study, multi-center again, comparing now gastric electrical stimulation to G-poem, retrospective trial, 78 G-poem, 33 GS. Response, which was time to hospitalization, was better in this group, and this just shows you the G-poem versus gastric electrical stimulation and diabetic versus idiopathic gastroparesis. And the bottom line is G-poem do better in this presentation, and diabetic patient do better than idiopathic. This is something we know from electrical stimulation, the diabetic do better. Perhaps because diabetic is a finite etiology. Idiopathic gastroparesis, we don't know the etiology, so it's a mixed basket. Okay, so what have we learned? Open label intervention, and they all have been open label. If you do a myotomy, G-poem is beneficial. Besides etiology, are there any other predictors? Can we predict response by using, let's say, a dilation? Who will do better? Can we predict response by distensibility of the pylorus? And still, no sham control trials. And that's a pity, because this is an intervention that lends itself perfectly to a sham control, because you can do endoscopy, pull out, and this is perfectly ethical. You cannot do that if you're doing a surgical intervention. So I think there might be a merit, but there are too many question marks about this intervention, and I think that the sham control trial can be extremely helpful. I'll finish with this little study, which I liked. Safety of doing a dilation at the time that you're doing a disimpaction in esophageal impaction. So what do we know? You're run-of-the-mill patient with food impaction. You're called a Friday afternoon. This is late Friday dinner, and they wait a few hours, and it was a steak, and by midnight they get to the ER. Right? This has been my experience. You do a bolus removal, you take some biopsies, and then you treat the patient. Say, come back in a few weeks, because you're afraid that that bolus sitting there has created some ischemia, and you're concerned about dilating at the same time. This has been the conventional wisdom. And this is what I've done. I've taught fellows, still teach them. Give them some time, bring them back, do the dilation later. So they decided to look at same session dilation, because we don't have data on that. This is the study, prospective. They have excluded patients that had bone in the esophagus from chicken or fish, and patients with malignant stricture. They dilated at the same time to savory 14, 16 millimeter, repeated the endoscopy to see if there's any bleeding or tears, followed by phone or clinic visit, and looked at complication, bleeding, and death. This is just give you the statistics, 297 enrolled. They fish lots of foreign bodies in southern Australia for some reason. And this is the bottom line. Technical success, 100%. Complication, essentially non-serious, no mortality. So bottom line, perhaps another sacred cow down, and maybe we should dilate at the time, give them a little relief until the second dilation, and I think there should be a reasonable idea in centers with good expertise of dilation. Thank you very much.